this is pretty painful to say. We've worked with lots and lots of medical schools. Our experience has been that medical schools are fundamentally compliance organizations. And so when you have to do, show me your curriculum, link that learning objective to your multiple choice question, and show that that multiple choice question tested that learning objective. Once you start getting trapped in that administrative stranglehold, how do you change anything?
So, Dr. Tisdall, a viewer asked you whether what you're describing is problem-based learning, kind of what some of the medical schools in Canada are doing, like McMaster, University of Calgary. Is that similar to the method that you're prescribing?
Yeah, for sure it is, and there's actually kind of a cute history here. We're going all the way back to 1969. And this is a period of tremendous cultural ferment. This is when the boomer generation is coming of age. We're introducing the birth control pill. The Vietnam War is on. There's changes in the air. And into that period where anything seemed possible, two of the new medical schools in Canada started with a different premise. So understand what the classic medical school premise is. You do 1 year of normal. So that's your normal anatomy, physiology, pharmacology. And then your second year is abnormal. I mean, they gave it lots of names, the clinical year, all that stuff. But basically, it's when you did your pathology and prepped for your clerkship. Then you wrote a basic sciences exam, and having cleared that hurdle, you went to your clerkship. It's a good model. There's nothing wrong with subject-based learning. It's just that you forget it all after 12 weeks. Into that ferment, they were building new medical schools, populations were growing, and two of the new schools decided that they were going to have a much different curriculum. Everyone's clear on the problems with the subject-based. The trick is not throwing out the baby with the bathwater. So one of them was in Ontario, and this is 1969, and 5 sort of really disgruntled docs from Toronto said, let's not do that. And so they basically said medicine should be self-teaching and it should be problem-based. And they did that. Now, the challenge they faced was they did this sort of self-directed learning while they still had conventional testing. So that kind of didn't go well. So they had to adjust on the fly, but they certainly did that. And then Calgary, we're talking Calgary's first class is what, 1970-ish? Well, I started med school in 1972 and I live in Calgary. So that was something that was very real to me.
You went to University of Alberta or University of Calgary? Where did you go?
I did my undergrad at University of Calgary because I was totally broke, so I had to live at home.
That's right.
Yeah. So I'm living at home, driving up to the university, and so I'm well aware of this program. But, I'm a pretty broke kid. And so University of Calgary is starting, and they see what's going on in Ontario, and they go, that's a really good idea. So they're going to start that too. My problem was this. I had a 4-year scholarship, and after that, it was debt city, which every current medical student understands perfectly. And so I got accepted to med school after 2 years of undergrad. So I was accepted at both University of Calgary and University of Alberta. So I really had a deep, deep series of thinking about this. And I realized, I didn't have a deep science background. I only had 2 years. And I was pretty young. I mean, I'm only 18. And the thing about self-teaching, problem-based learning is it requires a lot of discipline. And remember, they don't get summers off. Calgary goes straight through for 3 years. So they get as many months of medical school. There's no sort of resuscitation period. And I kind of felt I had too little science and I was too young. So I went to the conventional medical school up in Edmonton. And that worked great for me. But fast forward, I actually interned with a student who graduated from U of C. So I actually got to see what would have happened to me if I had done that. And so there's no question, when you do it straight through, you give up a lot. You really do. Taking a summer off to recharge after the intensity of a year in med school, I think is very beneficial. I've never quite understood this need to rush through. I think I like the idea a lot of work hard, let it settle, come back, work hard, let it settle. I kind of like that. That works for me, and I think it works for most people. So what was the U of C student like? Well, the answer is this. Medicine is an apprenticeship. So when you do an intense apprenticeship like we did, he started significantly behind because obviously we'd done 2 years of clinical and he'd done 1. And he caught up after about 2 months because you learn what you got to learn. So if anything convinced me it doesn't matter where you go to medical school, once you start clinical medicine, you'll be as good as you're going to be. I still believe that. The question is, however, are there now tools that work better than back then? Here's what's impossible for you to understand. We used to sit in a classroom in which the professor would get up and read from a piece of paper, and we had to take notes. And you got the pathologist, and he would put a Kodachrome slide up, projected at like 5 miles. And my entire memory of pathology is blue dots in a sea of pink. Every friggin' picture he put up looked like a blue dot with a sea of pink. I'd never had any idea what he was talking about. And so in that sense, it looked very classical and very spoon-fed. Quite the opposite. You know, they bored us to tears reading in the morning, and then we got our bad notes and our books, and we made our own learning curriculum. So it's easy to look at the spoon-fed. Yeah, it really wasn't like that. Clearly, the quality of the student matters. So what's the right answer? The right answer is we have different tools now, and we shouldn't be looking at these old models. Because I can go on AI. I do it every hour of my day. I have a conversation with AI about medicine every hour. It's really good. I get it, all the caveats. You got to be careful. It won't tell you when it doesn't know. It has hallucinations. I get all that. But it's easily worth it. So if I can have someone tell me what I should be learning and then test me on whether I learned it, you come to this horrible question, why do we need medical school for the first 2 years? And, you know, as you know, there are members in my family that believe that if they could just do my curriculum, they could pass the exam just on their own. And I know that's true. So I think the whole thing's in revolution right now. I mean, any medical student in the world can come and access me and do this. And in fact, you know, as you know, I'm working with a medical school right now, and the students say, what should I do? And my first question is always this: are you passing your courses? And if the answer is yes, then I say this: then continue to pass your local exams, but make sure you're also doing pathophys clinical correlation, because that's your final exam and your clerkship. And so we've got these sort of dual tracks. We've got this legacy track where they learn a bunch of random facts they're going to forget in 12 weeks. And then they have to come and say, let's do problem-based learning. So I just looked up to see where University of Calgary is now. And, you know, here's what you got to remember about University of Calgary. First of all, they have 4 major medical schools, 4 major medical institutions for 400 medical students. So, boy, that's really great clinical exposure. There are a gazillion doctors watching those students. You could have any program in the world. They're going to do great because that's an apprenticeship. So right off the top, you just tell me, I have 4 major hospitals and 400 students. Stop. Everything's going to be fine, right? What they did, though, as I dug that out, they have what they call a black book. I guess I sort of knew this, but I looked it up. And their black book, and I'm not making this up, Ali, their black book is their chief complaints. So when they say problem-based learning, they say these are the 125 plus or minus problems that appear in medicine. Well, they're not problems. They're what I call chief complaints. So I went through them all. They're perfect. It's fantastic. You go, well, why do I only have 50 and they have 125? Well, because they take the CBC and they break it out into 8. Well, I give you anemia, you know. So they break things out into miles of things. I sort of break it down. So I went through all their algorithms. This is exactly how medicine should be done. I mean, I really liked it a lot. It's all the same algorithms I use. There's nothing magical in medicine. Here's, if I have to, small little quibble. I mean, honest to God, it was great. But my small little quibble is this. It looked as though it had kind of been done by a committee because they couldn't, they broke the first rule of algorithms. Don't try to include everything. You know, so if you're doing anemia, you don't have to do acute blood loss. Pretty sure I know they vomited blood on the floor. But you can just see the committee member, hey, what about, you know, no one's going to take it on. Fine, just put it in. The second little quibble I have is they were they weren't 80-20. You know, they had the same problem you have when you're using Harrison's internal medicine. It's written for a higher level of understanding. It's not written for a first and second year medical student. And so I cut out lots and lots of things that you are going to need, because first time through, let's get the big picture right. And then we can worry about all the things that are going to be added in. Okay, a couple little quibbles. I'm sure there's not a single person who wrote that table couldn't tell me all the problems they had in committee. I think it's great. So what's the challenge at University of Calgary? Because let's stipulate right off the top, that's the right way to do it. Lots and lots of MDs, lots and lots of clinical exposure, all based on important chief complaints, chest pain. Can't go wrong. The challenge comes down to this idea that clinical medicine is built on a foundation of basic medical sciences. So I love their clinical program. Here's what I know they're not doing, because I actually asked one of their faculty this question. The question was this: so when you're teaching your organ system with the students in first and second year, do you teach the basic sciences? Are you teaching the immunology of granulomas? Are you teaching the anatomy? And his answer was, no, I have a PhD to do that. Well, yeah, no, I stop right there. That's not integrated. That's not building clinical medicine, because here you are, the professor of your specialty. You're held up as, this is who we look up to. This is a master of our subject material. That's true. And the student has to note that that individual actually can't talk about interleukins. Well, he's totally successful. He's the winner of the pie, right? And yet he somehow made it without knowing interleukins. Got it, says the student. I get it. I'm memorizing this for exams. Check the box and move on. But I don't believe that. You see, I don't believe that. I believe that if I understood the basic sciences underpinning granulomas, I would actually be a better doctor. And I'll give you a classic example. Okay, so, you know, I've got this long career, and I actually worked for a while in a skin pathology lab. And so I saw a million skin biopsies. And psoriasis back in my day was a disease of neutrophils. That's the hallmark of the disease, right? You see a little neutrophil bubbling up, and that's why they get the scale and all the things to go with that. Well, now we know that it's intimately related to signaling of neutrophils by interleukins. So if you want to understand psoriasis now, you actually have to go to the treatments, which are IL-17, 21, 22, which are the interleukins that signal neutrophils. So back in my day, basic sciences was, this is what the biopsy shows, you see that. But now we know all the molecular signaling under that, and it's targets for pharmacology. So don't you think that if you're a true medical educator, I don't care if your specialty is heart, lung, or kidney, you should still understand the interleukins, and you should be perfectly comfortable talking about psoriasis and the interleukins for neutrophils. It makes you a better doctor. So love what those two schools are doing. We can talk about all the particulars, that's fine. But I would argue anytime you have a million MDs and lots of clinical opportunity, the only thing you're missing at that point is, who are your medical educators? Who is telling you, hey, let's just sit down, let's just draw how I think about the celiac axis. If you can't do that, I guess I sort of have to say, God, I'm not saying you're not a practicing clinician, but you're not building your clinical medicine on the basic sciences. And I include myself, you know, I came out of practice, I couldn't either.
One thing you mentioned is that the problems, chief complaints that UFC has, they almost go into too much. And just for anyone listening out there, we do have a session recorded with Dr. Tisdall on what you don't have to know and what you don't have to learn, which is almost as important as what you do, because you can just overload yourself with information. So there's that. The question I have for you is, the comment says that there's still a lot of resistance to this problem-based learning, which from my perspective, it sounds like the right method ultimately. Why are other institutions hesitant to adopt the approach?
So this is pretty painful to say, but, you know, we've worked with lots and lots of medical schools, and our experience has been that medical schools are fundamentally compliance organizations. And so when you have to do, show me for my licensing body, show me your curriculum, link that learning objective to your multiple choice question, and show that that multiple choice question tested that learning objective. So once you start getting trapped in that administrative stranglehold, how do you change anything? The second problem you have is, remember how we described Calgary? It has like a gazillion MDs across multiple big organizations. They have lots of MDs to teach. Well, if you're not using clinical MDs to teach, you're paying faculty who are MDs. So right now, I'm making a third, as a full-time faculty member, I make a third of what I made in clinical practice. You sort of have to be this old and retired to be able to afford it. So you're not going to be able to get the MDs that you want. And remember, when you get them, they can't connect it to basic sciences. No one ever taught them, and where do you go to learn it? That's why I had to write my book. So you're going to bring people out of clinical practice to earn a third less and tell them they have 3 years of intensive learning to understand why they did what they did. Okay, that's not an easy sell. Why then do we have PhDs teaching? Because if you don't get your research grant, as a PhD, what do you do for your career? Well, you teach. Well, where are you going to teach? So we have this huge manpower available of all these PhDs who are more than delighted to teach their subject. But when you say to them, I get it, that's a really nice discussion of calcium in that cell. Tell me why I would care in patient care. Well, they don't know. They just don't know. And when you say to them, okay, so why don't you become a medical educator and learn it? I mean, obviously, we're taking first-year medical students. It's not like there's some magic in learning it. You've heard me say a million times, medicine isn't hard, it's long. And so why don't you just learn it? And I got to say, in all my more than decade teaching, I've met only a handful of PhDs who were prepared to do that. Most of them just say, no. We're comfortable. We like our life. And the answer is that looks like a lot of work, and I'm going to be embarrassed all the time because I'm going to be a student again. So the answer is no. Every medical student you go to, every medical institution you go to will tell you, we want to integrate. Everyone uses that word. Well, I have a definition of integrate. Integrate means the practicing doctor uses basic sciences as part of their practice. It's that good now. And I had this very dispiriting moment a couple of weeks ago. I was talking to a medical school, and they're coming up to their second-year curriculum where they do, I'm not making this up, the word is clinical integration. And all the faculty are there, and what they concluded was the best way to do this was for each of the PhDs to submit multiple choice questions. Well, no, that's not clinically integrated.
How did that go? Yeah.
I didn't say a word, because what are you supposed to say, right? What you're supposed to say is, well, that's not what integration means. But think how useful it makes them. They're all busy. They're all writing these really thoughtful multiple choice questions, but there's no why involved. And the second thing that really grinds is, why multiple choice questions? Why are we so married to this tiny little tool in learning? I mean, somehow we got stuck on multiple choice questions 20 years ago, and we've never been able to unstick. Now, I can tell you why. First of all, it's really good for computers, right? It looks really official. You can do A through E. You can scale it. You can do all sorts of statistics. Is that a good question? Did it get good separation? How did it do with the good students? Yeah, all the stats are great. But there's no part of that stats that says, yeah, but is that an important question? Because here's what you got to understand. There's 3 types of testing. There's motivational testing. We all need that. Hey, you lazy dogs, we gave you the assignment last week. I know none of you done a stroke of work on it. I'm just going to test the living bejesus out of you, so get on with it. We all need that. That's very healthy. The second is, did you understand the material? Have you mastered it? Because medicine is mastery. So I would argue a true mastery exam would say, these are the things you got to know coming out of congestive heart failure. You have to pass that exam at 90%. I don't want a doctor that's mastered 60% of congestive heart failure. You've mastered enough, or you haven't mastered enough. So in that sense, it's pass-fail, but it's not pass-fail. It's, have you mastered enough to go on or not? That's what I think most of our testing should be. And then the third is we have testing for ranking, because it's a competitive world, and somehow we think that marks somehow correlate with something in medicine, which they don't, but here we are. So multiple choice questions solve a problem that doesn't need solving, because it doesn't predict whether you understand the material particularly well. And yet here we are, we're stuck on it, and it's impossible to get out of. I mean, this will shock you, but when I wrote my fellowship exam in Canada, I had an oral exam. And if you've never done an oral exam, this is what I can tell you. As you know something really well, you go through it really fast. And when you don't know something very well, it slows down. They go, ooh, let's explore that. That wasn't a very good answer. And so everything you don't know becomes most of the exam. Everyone comes up and they're all convinced they failed, because everything they knew took 10 minutes and everything they didn't know took like an hour and a half.
Is there anything like that nowadays?
I don't think you can, because everyone's a victim, right? You're not allowed to say you're not good enough and have someone say, well, thank you. I would not want to go on if I wasn't good enough. We've so lost trust and cohesion. You can't say, well, here's your score on the multiple choice question. See, 80% of the students got it and you didn't. You're not allowed to say, well, it was a stupid question. I didn't want to know the blood supply to the ureter. Right?
Yeah.
So I ran tumor board for a gazillion decades, right? I mean, tumor board is just part of every pathologist's life. And every hospital in America has one. So every hospital has a tumor board where you talk about everything to relate to cancers that week. And it's presented by varying people. In my practice, it was me. So you can imagine what I didn't know. I mean, tumors in my life. So I'm at a medical school, and I happen to be not teaching for a 3-week period that the students are doing molecular neoplasia. And understand, that's really pretty new, you know. When I wrapped up in 2010, we were just getting the first useful molecular. That's how new it is. And so I said, well, I better go to the course because I just don't know it. I mean, it wasn't in my practice. And I sat through the course and went, I didn't understand a word of it. So that break, I spent every morning for a month mastering molecular neoplasia. Understand, this is someone that's done tumor board every week for 40 years, right? Got it. This is really magical. I was really dazzled. This is chapter 13 in the book, by the way. And so I went back and then wrote the exam that the students I went through the course wrote. Okay, you ready for this? They averaged 86% in the exam, and I got 68%. In other words, I scored 15, 20 points below them. And of course, the PhDs thought that was the single funniest thing they'd ever heard. Everyone knew MDs are just plumbers, and doesn't that just perfect? They're not as good as medical students. What they failed to ask themselves was, why is someone who has lived and breathed this for decades only got 68%? They never asked themselves, maybe it's a stupid exam.
Yeah, maybe they're testing for the wrong thing.
Yeah, maybe when they ask, is that enzyme a dehydrogenase or a phosphatase? I went, I don't care. But they never asked, Allie. They never asked. It became a hilarious standing joke in the school. But when the students came to pathology the next semester, and I'd say, why don't you tell me about the molecular? Could they? No, they'd memorize, check the box. They had no use for molecular in their clinical skills, and I had to reteach it.
Med school companion is really meant to be a companion, not a med school. But
right.
If you were designing a curriculum today, what would you keep from those traditional models and what would you change and throw away?
Well, you know, here's the weird thing. Subject-based learning is really powerful after you know the diseases. So when I was doing exam review, you know, general pathology is the basic sciences of clinical pathology. When I was doing a review course, I would do the general pathology at the end of my course when we'd reviewed all the diseases, and then you'd see all the connections. So you need to do it twice. This is my opinion. You need to do it twice. You need to do a big picture story. So if I almost went to a med school that offered me the first 8 weeks. Because what I would do is the Reader's Digest, how to think about anatomy. Every anatomy thing should be a system, circulatory system, nervous system. Just how to get enough that I can take you into the organs. And then after you've done the organ systems, then I would take you back to the subjects, because now when you've seen staph infecting skin and then a heart valve and then an intravenous device, now all of a sudden you say, I'd like to know more about Staph aureus. So I think a little subject intro, deep clinical based on connecting to basic sciences. The time for deep dives into subjects is after that. So I think clerkship would be a perfect time to do microbiology because you know enough to make it interesting. It's useless before then.
You mentioned how to think about anatomy. You're using that as an example. Well,
Yeah.
Another viewer asked a question about anatomy, and their comment was that most anatomy resources, Robbins included, feels really theoretical and disconnected from real clinical decision making. What are your thoughts on that?
Totally agree with that. That's a perfectly fair comment. And this is where you see PBL, problem-based learning, or my way of saying that, chief complaint to differential. This is a really good example of where that's really powerful. So let's just take a look. If you take a look at how we do every system, we start with clinical pathologic correlation. So those are the chief complaints of heart. There are 5. Here are the chief complaints of lung. There are 2, shortness of breath and cough, right? Kidney, ooh, that's awkward. There's 7 or 8. So, but every chapter starts with, you have to be able to do the differential from this system when you finish. But the next thing is structure function. And you'll notice the way I do it for every organ system: regional, surface, internal structure, because that's what you're going to see with all your imaging. Then we come down and say, show me the architecture, show me the cell, show me the ultrastructure. Now build the proteins from DNA. So when you say it doesn't lend itself to anatomy, yeah, it doesn't do that, does it? Because how can you do heart in the thorax if you say, well, what happens to the heart when I get a tension pneumothorax? If I say to you, let's do esophagus, and I say I've got a mass in the esophagus, could I see that in the mediastinum? Well, the answer is, I don't know. You got a picture of the mediastinum in your head? I bet there's almost none of my listeners out there would be comfortable drawing a picture of the chest and on it putting, and this is a lateral view, and put it superior, inferior, anterior, middle, posterior. Everyone feel good about that? Well, let's just say until I had to start teaching, I wouldn't have felt good about it. And so this is where the idea of a medical educator comes. Once you understand how clinical medicine works, then you can go to every chief complaint and you can say, well, this is not an anatomy-based problem. Oh, this is deeply an anatomy-based problem. It's not the same for every problem. So that's the failure of courses, is it makes everything equally important. When you do patient-centered, you realize, no, you kind of got to know where you are. What do I need? And so for me, it's very much just enough, just in time. Sometimes it's anatomy, sometimes it's biochem, sometimes it's physiology. Every problem has a different core pathophysiology, and that's why you need a medical educator.
So if you were sitting down with a first-year medical student and they're like, haven't taken a single class yet, how would you coach them on how to study anatomy so that they're starting from the right place from day one?
So you've got to do 2 things. You've got to do your subject, and you've got to do its clinical relevance. Here's what I'd say about anatomy, and I mean this, I'm not kidding. If you can't draw it, you don't know it. So if I said to you, I want you to draw the arterial system, here's a blank piece of paper. If you can't do that, you're just making words up. You know what no one can do? This is one of my favorite questions. So there are 3 major venous systems. And then there's a 4th. So everyone with a little help can do the first 3. Okay, there's the systemic inferior. Oh, pulmonary, that's good. The portal system of the kidney. Yeah, no, got it. No, thanks. What's the 4th? And frankly, Allie, I didn't know there was a 4th till I was writing the book. I mean, I'd referenced around it, but I didn't really know it until I just had the time to say, so where did that come from? And I followed this little guy all the way back and I went, wow, how was I never taught that? And just so that everyone knows, that's your vertebral spinal cord. And get this, it drains into the, yeah, right, not a clue. I didn't have a clue either. This was really fun to learn. Into the azygos. And then comes the magic of really fun learning. You go, so why is it called the azygos? And the answer is because all the original anatomists were European scholars and they all spoke Latin and Greek. So that's the root of all this stuff. A means without, and zygote means twin. And this is the only vein they found that didn't have another one on the other side. So they called it the azygos, the vein that didn't have a match, wasn't symmetric.
We definitely need to do an episode on
On etymology?
etymology and where these words are coming from, because I know when I was doing my own pre-med years ago, the words didn't make any sense to me. And so how do I remember them if I don't understand where they come from? Your textbook does such an excellent job at the drawings. To draw it is to know it. If you don't have a copy of the textbook already, be sure there's going to be a link in the description. Be sure to get yourself a copy. There's a volume 1 and a volume 2. And you do that really well. And the nice thing about once we get our community going is that you're going to be able to go live and present your screen and show yourself drawing it, and then have the students go and they need to practice drawing it. And what do you always do with algorithms, tables, drawings before you go lecture? Do you go practice them?
Always. And
Yeah.
I made them up. And I've been doing it for over 10 years. And I practice them. I always say to the students, so do you think a concert pianist, after they do a beautiful recital, do you think they go, oh yeah, got that one. Oh, wonder when I'm going to go screw around till my next concert. Or do you think the next day they practice their scales? Yeah, well, that's pretty obvious, right? Practice.
That's very obvious. Dr. Tisdall, I have one more question for you, sort of a bonus question.
Oh, I like it.
What's the single most important mindset shift a med student needs to survive and thrive in today's system?
You have to have a tight, essential mental picture of the key pathophysiology for every disease process. If I could make anything go better for a medical student, it would be when I say sickle cell, what is your essential word? And the answer is, not sickle. It's microvascular occlusion. If I said to you hereditary spherocytosis, do you have an essential mental image? And the answer is, can't adhere the membrane to the cytoskeleton. When you can do that, everything orients around it. And I got to tell you, if you're watching my eyes, I bet I looked up when I said that, because I was going up to my mental image. That word created a little mental image. I went, oh yeah, there's all my little alive red cells sticking to the endothelium, blocking off that little artery. Oh yeah, that's right. Micro, it's not a big vessel, so it's a microvascular occlusion. And so one of the things we have to do in our community is I think we're going to have to, I hate to say it, sort of do cards that let you practice what's the essential. Because it's not just enough to have the cards, Allie. You got to have the right pathophys. And textbooks don't do that. Right? Because they're all blah, blah, blah. Here's 3 pages on it. But they don't say, hey, when I say pneumococcus, what do you say? The answer is, ooh, gram-positive capsule. Good. Did you see? I have a picture of the gram-positive wall on a capsule, by the way. I could walk you straight into that molecular, because that's going to be really important when I come to inflammation and I talk about PAMPs and DAMPs. So, yeah, if I could do anything, there's nowhere to get that. And that's going to be one of our first projects in our community, which is let's practice these, and then you've got that really quick orientation and you can build out from it.
So to give you guys an update on where we're at with the community, we do have a system in place right now with a website with a ton of resources. That's mscmed.com. We are working on a version 2.0. And in this one, it's going to be a downloadable app or a website that you can go to. And we're going to have videos from Dr. Tisdall. We're going to have test prep questions, cards, as you call it.
Yeah, we're going to have
We're going to have to. We're looking at how to integrate the textbook into it as well. I think the most valuable resource is access to you, which will be frequent lives.
Yeah, it's really motivating to have someone come and rag on you and sort of and make you want to be better. One of the things that I've always been impressed by when I'm teaching is that afterwards the students want to go study. They go, God, that was just great. I really want to know that. And the answer is, yeah, well, me too. When I get off this little video, I'm going to go working on the aorta, and I'm really looking forward to it.
Yeah. I think we're going to have we're looking at two possible different ways to get you live. One is one directional, where people can just type in like questions and you can answer them on the go. The other one is looking at small group sessions where by invite only, you have a group of students that you are also live with you, and everyone can go watch, and then the recording will be available later. So all that is coming, and hopefully in the next weeks to months. We're really excited by it. And if you haven't already, be sure to subscribe to our channel to stay up to date so that you are in the know once all these things are launched. As well, if you liked this conversation, be sure to check out our most recent video of Dr. Tisdall Unfiltered, where we talk about how to train medical educators to teach students how to think like doctors. So, Dr. Tisdall, it's been a pleasure, and
Always.
we'll see you next time.